OK. OK. Marcelo, tu peux ouvrir YouTube maintenant. Ouvre
Oui,
YouTube.
il est ouvert déjà.
OK. OK. Good morning. I think good night. Good morning every morning for this session of the staff of the Compagnons Hépato-Biliares. We will start immediately by the answer of the cases presented last month. At that time, the presenter may only say one word about the case. Valerio, of the Compagnons Hépato-Biliares. You speak about the case you presented last month. We will
yes, sure.
start
I will show a picture. So just to remind, I was talking about liver metastasis of undetermined. Wait, do you see my screen? Do you see the picture?
Yes.
So, as you see here, it was a young female patient, 57 years old, with a metastasis, suspected metastasis of a cerebral tumor, where we discussed about doing a biopsy or not. You see a huge mass. That we operated on and had concomitant pulmonary metastasis, as we see here. And we operated her and we made a right extended hepatectomy of a 1.9 kilo liver. So it was quite big, 20 centimeter big mass. Unfortunately, I don't have the images, but it confirmed our diagnosis of hemangiopericytoma, so 13 years after a primary resection in the cerebral mass. So it was a right anterior, a right extended hepatectomy for a 1.9 kilo mass, and everything went okay. She will undergo a lung resection of metastasis on near beginning of September.
Okay. The technique, the usual. What was the technique? The usual technique.
So I did. It was impossible to mobilize the liver, and so I did a real pure anterograde approach of the liver with a Pringle maneuver, because it's the mass stretched the right pedicle, and so I did a classical anterograde way, taking out also the segment 4, so a real right extended hepatectomy.
Other comment? Valerio, expected prognosis.
So the expected prognosis should be good, even though the risk of recurrence is high, but it's a quite slow growing tumors, and the chemotherapy doesn't work good for those kind of tumors. And so, when it's resectable, the advice of the neurosurgeons is to take out those metastases.
René, you approve for no chemotherapy?
This tumor is not so very chemosensitive, to my knowledge, but have you tried with your medical oncologist to find any, because we have new therapy, we have as you know, the target, not only targeted therapy, but also immunotherapy and so on. Have you explored a little bit such type of treatment as an adjuvant way, at least?
So it doesn't have, they discussed, so the multidisciplinary oncological staff meeting, they advised to take out to resect the liver, the metastasis, the different metastasis, and they want to keep chemotherapy for a second stage if there is a non-resectable recurrence.
Okay.
And so they advise for the lung metastasis, they advise to take them out, the resectable, and to treat by stereotactic radiotherapy those who cannot be resected.
What I mean is that your oncologists do not believe in chemotherapy. Because
for this tumor, yes, exactly.
Okay. I think Hugo is here. Hugo? Is Hugo? No. Hugo is not here. No. Okay.
I am here.
Yeah. So I asked you a question, but we will not comment. He did this resection by an anterior approach. In your hand, did you have performed this by robotic surgery?
Not the anterior approach. We have done some right hepatectomies, but not by that approach yet.
No, I mean in this case, you see the patients.
Yes. I wouldn't choose a robotic approach for this, I think.
Okay.
No.
Okay, good. So we go to the second case. Rashad?
Yeah.
Thank you. Valerio, it was very
Yes.
nice. You did well. Thank you, Valerio.
Thank you.
We go to the case of Rashad.
Yes, I'm presenting. I'm just showing it. Yes. Yes, just to summarize, he's the 26-year-old patient who 2 years, 3 months ago, he had a perforated rectosigmoid tumor. He had 2 courses of chemotherapy, and despite that, he developed his stage 4B with liver metastasis, abdominal wall metastasis, and pelvic metastasis. And we discussed him last month, and the decision was to upgrade the systemic therapy by adding a targeted therapy. And we discussed it with the oncologist and decided to go for Folfox and Vectibex or panitumab. They said, I mean, he already had the Folfox and the Folfiri, and he was due for the Folfirini, but they considered he was not up to it. Unfortunately, just 1 week, last week before coming, he came with episode of vomiting and small bowel obstruction, and he developed anemia and edema of his lower limbs. And that's the X-ray, and the CT showed that there was a progressive metastatic disease, and the small bowel loop wouldn't pass. Probably, he is, as it was pointed out, he had a carcinose peritoneal. The metastasis in the pelvis was adherent to the small bowel. We only treated him conservatively with pain control, blood transfusion, and he started slowly to improve. And in fact, he asked to take a home leave because he's terminal, and we said we agreed for him, and we're due to see him. Hopefully, he will settle, and we'll plan to do the systemic therapy with the targeted therapy for next week if he's well. If not, I think we'll only have the palliative treatment to continue with him. That's all I could say about this case. It's an unfortunate case where we know that as it was pointed, but if there is any more changes, I may inform you in our next meeting. But thank you very much for your advice for us last month.
Thank you. Any comment? Comment of the case of Rashad? Sheena, you are here. I see.
Thank you very much.
Okay. Hugo?
Yes. So let me just put the case here. So if you recall, the last meeting, I presented this case of this patient. Sorry, I'm not being able to present this. I don't know why. So I presented the case of this patient, 35 years old patient with a clad skin tumor that was invading the head of the pancreas, also an advanced tumor. And we discussed whether we should do preoperative chemotherapy and what would be the operative approach for this patient. And so after these options, we ended up deciding to do a embolization with a hepatopancreaticobiliary, which was what we did. This is the embolization of the right and middle hepatic vein and the branches of the right portal vein. After embolization, after 21 days, we had a functional liver remnants for segments 2 and 3 of only 24.9% in the cholestatic patients. Still, the graft weight to body weight ratio was 0.9 because she weighed 51 kilos. So we decided to move forward. And we did. This is the aspect of the liver. As you see here, it was also invaded the portal vein. This is after the resection. Here you can see the right extended hepatectomy extended to 4 and to 1 with portal vein resection and use of a cadaveric graft for the portal vein. Here you can see the Doppler after the venous reconstruction. And here you can see the biliary reconstruction and the pancreatic reconstruction. We use the technique described by Hasegawa and Kokudo and Makuchi as we already planned without virsongogestomy. So the operative time was 9 hours with 1,100 cc's of blood loss. And she's doing very well in the early post-operative period. This was last Monday. So this is all.
Thank you. Good case.
Can I ask a question?
Yes, go.
Of course.
Hugo, I am just surprised by the color of the liver, because if I remembered well, when you described your case at the beginning, it was an invasive cholangiocarcinoma, and the whole discussion was about maybe the infection and everything, and that liver doesn't seem to be so cholestatic, as I may say, because usually these livers looks greenish a little bit, very hard to touch. And actually, I'm surprised, and if it's this case, I can just congratulate you, really. So bravo.
No, it's true. In fact, when we discussed this 1 month ago, she was already drained by ERCP, which is not our preferred approach, as we all know, but she was. And she was already with a normal bilirubin level. And then we had 25 more days or so. What we found, this is something that when we do portal and sequential hepatic vein embolization, usually the liver is atrophic, but what we found here with the simultaneous embolization is that the right liver was very swollen and filled with blood. Still, we managed to do the hepatectomy without any kind of difficulty.
Yeah. Hugo, can I go back on the CT scan? Hello to everybody.
Hello.
I see a fairly big segment 4, and yes. In my quick look, it did not embolize segment 4.
Yes, we did not.
Right.
I can show you here.
Yeah.
Again.
This is what I thought. What do you think about embolization of segment 4? And if it's not too difficult, we tend to do it.
Well, there is, as you know, a big debate whether it is useful or not. But besides that, we had 2 other problems. I was not very happy with 25% of liver remnant for one side. You can leave part of segment 4 if you get the negative margin close to the hilum at the section of the biliary surface. So I wasn't really very worried about embolizing segment 4, because as you can see here in the image, we even left a small portion of it.
Yes, and in fact, I'm less, provided that you do a good dissection within the round ligament, exactly. Which I can't see in your reconstruction. Sometimes the bile duct of segment 4 comes so close to the bile duct of segment 3 that you can leave, in fact, segment 4 without losing length of radicality.
I don't know if you can see this, the central image, but in the central images, what
yes, you
you
left
see
segment 4.
the most, a little bit. And
no, you left almost. I mean, look. You left all of it there in the small square up there.
Yes.
You left all of it, and I'm going quite the right way for Klatskin tumors, where segment 4 inserts very close to the ducts of segment 3 and 2. Because in fact, you don't lose radicality and you gain in terms of parenchymal mass.
That's what I think also, yes.
Yeah.
And as you can see here in the middle image, the left branch of the portal vein, which should be intrahepatic, is totally dissected in there.
I can't see that because there is a picture, but I see exactly what you mean. Yeah, very interesting.
Okay.
You did, of course, en bloc resection.
Yes, I can show you here with lymph node clearance and pancreas and gallbladder and the right extended hepatectomy.
Yeah. And tell me more about your pancreatic anastomosis. You seem to be proud of that.
No, actually not. I can tell you that usually don't use this option, but we use this as we planned in the meeting before. And I can tell you that the post-operative period is being excellent. Of course, we will have to reconstruct the pancreatic oxygenostomy, but this way the pancreatic juice is not activated, and she's doing really very well.
Yeah, good.
No other question? No? Okay, thank you a lot, Hugo.
Thank you very much.
A nice case. Now we will like to have Dimitri. Dimitri is not here. No. You remember the case of Dimitri was very difficult. There are a lot of discussion also after the session, and we don't know what he did. He's not here. Perhaps he come later. Marcelo, he say he will be here or not today? You don't know. Okay. So we go now to the new cases. Who would like to come to start? Valerio, you have a case?
I have a case also, if you want.
Yes, please start. Okay.
Anyhow, okay, begin, Hugo.
No, please.
It's the same for me.
Okay. So I can present very quick. This is a very simple case, a recent one that is not solved. It is a curiosity more than I think. So this case is about a female patient of 55 years old. The only diseases that she had prior to this was asthma, and she had a sleeve gastrectomy due to obesity. This is her medication. So she goes to the emergency department with a right upper abdominal pain with an anemia of 7.6. And on the CT scan, what we can see is a hemorrhage and a rupture of a large hepatic cyst in the small hemoperitoneum that we can see here. Mm-hmm. So this is
Can you show it again? Mm-hmm.
Any comments? This is what we found in the entrance of the patients.
It goes too quickly for me.
I'll try to. It is a little difficult to put it.
Are you sure that it's yes.
No,
Okay.
she had no prior imaging.
Okay.
That is true. So we are not sure of this.
But I think all of us have seen hepatic cysts that never complicate, occasionally to complicate. And I've seen in 2 hemorrhage in the abdomen from ruptured hepatic cysts. Now, what you do about that is another question.
One question, was it a hemoperitoneum or not?
It's a mixture.
Not. Yes, you have a little bit of blood.
Lots of cystic fluid and a little bit of blood.
Yeah.
Yeah, but not much intraperitoneal.
Actually not.
So it's not.
Here,
yeah.
It's encapsulated, I think.
It's capsulated.
Yes.
So that's why I am.
The liver.
So that's why I'm surprised, because her HB was 7.5. So she bled. So when you bleed, usually it's outside, but now it's inside. This is an image. So I need more information, actually. No, more tests.
Hugo,
yes.
At what time was done the angio-CT? From the time of the pain of the patient, and did you see any leak from arterial leak during the angio-CT in a way to do why not embolization, selective embolization, or not?
Yes, this was done about 5 hours after the start of the pain, a little bit more maybe. And what the angio-CT said, although the images are not very good, is that there is some component of fresh blood in here.
I think she has 2 cysts.
Yeah.
And one which has ruptured and the one which has not ruptured.
My feeling in that case, because I don't have the rest of the information, and I'm sure Hugo is going to give us, but I will do definitely an angiogram. This is my first step. I need to do an angiogram to see where it's bleeding.
I wouldn't.
So, well, we actually did an angiogram.
Yeah.
And I think I will show you next. Sorry, this is another phase that I didn't show you, but it is exactly the same thing. This is the angiogram. And as you can see here, I will stop the image here. Do you see something unusual?
Yes, there are some little things.
Yes, these are microaneurysms.
Yes.
Yeah.
This was described. This is something we have not seen, but this is actually the aspect of the liver when the angiogram was done. Multiple microaneurysms of the intrahepatic liver.
Small blush.
Yes.
Now, would you not have seen that if you had a proper angio-CT with arterial reconstruction, which is what you should have in these cases?
Eventually, yes.
Yeah.
Eventually, yes, Pietro.
Because what you've shown us is just a portal.
Yeah. Actually, let me go back. This is the portal one. Yes. This is true. The angio-CT was done in the emergency, and it was not.
It was not a proper one.
Yes.
Yeah. My idea is that if on a proper angio-CT you see no bleeding, generally the arteriogram is not contributive.
True. Although in this case they identified bleeding in the terminal branches in this angiogram, and they embolized it, in fact.
Yeah.
So you have a situation of intrahepatic microaneurysm.
Yes.
So you have to look for the cause. One of the first cause known, it's the Randiosler. I'm sorry to say, but it is one of the first cause because they developed the microaneurysm.
Why are you sorry?
intrahepatic microaneurysm. So I will go further for the, the test. That's what I said. I need more tests.
Yes.
So you have to go for it.
Is so this is the case. This is a very recent one, so we don't know anything more yet. We know that she don't have any other diseases. This is post-embolization. And what we saw is, in fact, that this is more frequent in polyarthritis nodosa and can happen in another systemic diseases like microscopic polyangiitis or lupus. As you can see here, this image is very similar. And also this has been described in patients without any other cause, or with the bacterial infections, or even C virus infection. So this is all we know for now.
Yeah.
But Hugo, what are the cysts? And are they real cysts?
We are not sure yet. So this has some days.
Because we'll it's incredible to have such a disease with microaneurysms, which is rare, and at the same time ruptured cysts. I mean,
yes,
the likelihood to have the two extremely rare diseases at the same time is unlikely,
I am not sure this is really a cyst or caused by the rupture of one of these microaneurysms.
That means hematoma. That it could be hematoma.
Yeah. Only, and the cyst being a red herring, nothing to do with it.
On the contrary.
So now Hugo, what do you propose as treatment?
Well, she is embolized, and that is precisely our doubts now. We are going to repeat the CT scan to see what is happening now after embolization.
Which branch you embolize? The right?
The right. Yes.
Only the right.
It was
I'd be much more selective. I'd be much more selective.
Yes. It was a distal embolization.
Exactly, distal. Yes.
Well, now you have to just to prove the diagnosis, I think. And you have to go for all the autoimmune profile, do eventually a biopsy of the liver, but maybe on the left lobe to prove the diagnosis. Because I've seen that, but it is a micro aneurysm that you can have inside the liver. You can have it also inside the head. And it's typical of this autoimmune disease, so you have to prove the diagnosis first. So that's what I will go now for it. All the biology tests, the biopsy, and etc. And even do an angio MRI of the head, because I've seen this patient, they can even bleed inside the head. So you have to do the map of all the vascularization of the whole body. That's what I will do. That's the first step.
Okay, no other comment? Okay. You will let know next month about the issue. John?
Thank you very much.
Thank you, Hugo. John, Isaac, John, may you present your case now?
Okay.
Oh, no, I'm sorry. I think Valerio was ready, no? Valerio.
Yes, I can present my
go on,
my
and
case.
the next one is John. Go Valerio.
Okay, so my case is for an advice. I need an advice of all of you. Do you see the presentation?
Yes.
Yes.
Okay, I already give the diagnosis, which is not very frequent in our country. So it is a young man, 32-year-old man, Belgian, white Caucasian, who lived in Europe, had no past medical history, and he arrived at the beginning of the month with a major jaundice, no pain, excellent general status, and on the ultrasound, a huge liver mass I will show you afterwards the images and dilatation of left intrahepatic bile ducts. So on biology, roughly the biology was normal except for bilirubin, which was very high, 17 milligrams per deciliter, which means 290 micrograms per liter, and the rest was roughly normal. Viral serology, so hepatitis B and C was negative, HIV was also negative, and on the MRI we see a huge mass, which is heterogeneous, which is hyperactive in diffusion, with no arterial enhancement, no portal enhancement. You see a huge mass, which is infiltrating the hilum. So to make a long story short, the serology of Echinococcus multilocularis was highly positive, and also the serology of Echinococcus granulosus was positive. And when we go to the image, there was also an extrahepatic seeding intraperitoneal. You see here nearby the liver, but outside the liver parenchyma, along of right flank, and going down to the rectum until all the plasma was filled of this mass. A transrectal ultrasonography has been done, showing a right anterolateral extrarectal heterogeneous hypoechogenic solid mass containing multiple small cystic lesions with sharp borders, but quite irregular. A transrectal biopsy has been done by the endoscopist, confirming the diagnosis of Echinococcus, so of Echinococcus multilocularis. This is the image in the liver. You see a huge mass infiltrating the hilum with a dilatation of left intrahepatic bile ducts. We can come afterwards back to the images. There's the diffusion MRI, where we see all the lesion occupying most of the right liver, and also segment 1, as we see here. So make the contour of the vena cava. On the arterial phase, we see that there is a patent left branch of hepatic artery, and also for segment 4. The artery to right liver is not visualized. And on portal vein, we see that the portal vein is patent. So portal vein here, left branch of portal vein is also patent, and the bifurcation is encircled by the mass. So we have all this huge right liver mass, dilatation of left hepatic bile ducts, which have been drained by endoscopic way. So they put 2 stents to drain left liver. And so, as we know, alveolar echinococcosis is a zoonosis, which is not very frequent here in Belgium. I know it's you see some in Switzerland. We begin to see some here in Belgium, not frequently, but it becomes to come. And when we go back to literature, we see that the prognosis is quite bad, with 90% of mortality at 10 years if they are not treated. And so in conclusion, we have very good shape with an obstructive on a right liver mass infiltrating the hilum and an intraperitoneal seeding of alveolar echinococcosis. So the CT scan of the lungs, so thorax CT scan and cerebral CT scan are both negative for other extrahepatic seedings. And so I have some questions for you. So do we need other exams to state that it is an alveolar echinococcosis? Should we do a PET CT scan? Should we do so histology in the liver? I presume not. Or should we do other exams? Is there an indication for surgery, knowing that there is a risk to be R1 or R2, mostly for the extrahepatic seeding? So other questions, more technical for the liver. So I think the mass is resectable by a Klatskin tumor resection, like Klatskin tumor resection with a right extended hepatectomy and resection of portal vein and common bile duct. So should we plan to resect IVC, as we saw that the mass surrounds the IVC? How to deal with the extrahepatic locations? Should we? Is this a nucleablo, or should we do extended resections? And do you think that those masses infiltrate the colon or the intestine, or is there some kind of capsule? I've never saw this. And about the treatment, so he began a treatment on albendazole, 400 milligrams twice a day. Should we do more than 1 month before surgery? Should we wait longer? Can we use extensively hypertonic saline, or should we care? There may be a problem of hypernatremia, and how long should the postoperative treatment after surgery last? 2 years or more? Thank you for your advices.
Okay. Thank you, Valerio. Thank you. Okay. Comment, question. I am a little surprised by this extrahepatic diffusion, mainly the peritoneal seeding. At my knowledge, the Echinococcus alveolaris diffuse only by proximity. That means diffuse along the portal trunk, along the artery, along the bile duct. It may go to the proximity, to the heart, to the vena cava, of course. Yes. But to have seeding, independent seeding intraperitoneal, I don't know a lot about that. Do you have experience? All the other, do you have experience about this kind of localization, extrahepatic localization in the peritoneum of this kind of Echinococcus?
If I could make a
Pietro,
comment.
Pietro, in Switzerland, you have some case of this, Pietro or Christian, no?
So yes, but as far as I could see on the CT scan, the peritoneal lesion is in close contact with the right liver, isn't it?
Yes, it seems to be a continuum, as you see here in this figure. It's all the right liver. There is some extrahepatic pericapsular seeding, and then it goes along the right flank and down to the Douglas. It's all a continuum.
Because as a rule, we only go for surgery if there is a way to resect all of the disease. So I couldn't see all the CT scan well enough, but you have to be sure to have a reasonable chance to remove all of the disease in order to proceed with surgery. And as a rule, the resection should be radical, like a no-touch dissection away from the disease.
Yes.
And I'm not sure that this is something you can consider in such a patient with such an advanced lesion. As a rule, we would do a PET CT with a late.
The problem is that Sorry, Christian. PET CT with
late phases. So it's a PET CT with acquisition of late images hours later, because these echinococcosis takes the PET CT very slowly, and usually there is an uptake, and this is something useful for the follow-up of the patient, especially if you don't proceed with the surgery, because you will put him long-term on albendazole, and you can see the response to the treatment according to a PET CT you might be doing later, like in 1 year from now, 2 years from now, with the uptake of the FDG, which could be fading away with the treatment by albendazole. But I would think that without being able to resect all of the disease, I would be more keen on putting a stent and putting the patient on albendazole. But I'm happy to hear Pietro as well.
Yeah, you are a perfectionist. I can live with less optimal results, because this is a young patient, isn't he?
Yes, 32 years old.
So you have
perfect
you have to go on for a very long time with on and off albendazole. One of the problems is that they will have to take it for life. It is not a medication that at 32 you want to take for 50 years. So I would be, and also Christian is right that the aim is R0 resections. But you can, since it's a very slow disease and you can monitor it for a very long time, I would also consider resection, because and a more stable biliary drainage than simply having a stent for this patient. If you have some small foci of disease that stay behind, you can monitor the treatment with albendazole when it's and once it's almost one disease. This is what I would say. You can treat them with albendazole, check that the disease is completely turned off on the PET CT, and then stop the albendazole, follow them up, and if the disease flares up again, with yearly PET CTs or 2 yearly PET CTs, then restart the albendazole and stuff. The person who knows this disease best is Solange Bresson-Adny and her team in Besançon. And we constantly discussed with Christian and Gilles our difficult cases, some in the pediatric age with her. And my way of thinking of the disease now is that you operate for the complications rather than to eradicate the disease, unless it's a simple surgery that you can eradicate. In this case, I think it's one of the last moments in which you can operate this patient to make it long-term manageable with on and off albendazole. If you don't do this at 32, when the disease is like this, you miss the boat. So in principle, I agree completely with what Christian has said, but I would adapt to a less optimal resection, because that would provide me with a more stable biliary drainage than simply a stent.
I think the key there is how much would you need to leave behind after surgery?
A big pun?
The key is how much you need to leave behind after surgery.
I think I was surprised in this. I mean, I haven't done many, Christian, but I've done at least 2 of these cases in which I was surprised, and one was a transplant, in fact. In fact, 2 were transplants. We transplanted 2 patients, and we resected, in my experience, around 5. Not having an R0 was not completely an issue, in fact, in real life.
if I may make a comment, Valerio, with quite a number of those kind of patients in our cohort, so obviously the treatment with albendazole is mandatory. Looking at the results, of course, I agree with Pietro that it's not lifelong treatment. So I would go rather towards the resection. Unfortunately, this alveococcus behaves like neoplasms, except giving distant metastasis. So R0 resection,
and being very slow.
Yes, but R0 resection is mandatory, if ever. We have successful results with about 10 patients, similar patients, with the liver transplantation. The only concern is the problem of the resection of those grains of the right flank. But yes, I think the general idea is the resection if possible, if not, transplantation.
Yes. But in this case, should you have
quite important extrahepatic seeding? I'm quite scared about this. I think I was my question was, should I operate on this patient or not? Because there's already an infiltration of the pedicle of the hilum, so it's for the liver. It's either now or never, probably.
Yeah, it's going to progress.
The seeding will go further left, and then it's a point of no return. So I understand perfectly the position of Christian, who says, if it's not R0, we shouldn't do it. Okay, it's true, but the guy is very young, in perfect general status, so probably we have to be a little bit more aggressive.
Valerio, yes? Valerio, I think you're right, and I agree with Pietro in the management for two reasons. He's 32-year-old. This drainage, he's not going to live forever with a plastic stent. So, and in my knowledge, personally, I've never seen, so it was very strange to see that he has a rectal, a colonic metastasis, so to say. So here you have to have a best management for him because it's a very slow growing disease. And I believe that you're right in a way that I think, in my opinion, it's a good timing to consider resection with an optimum biliary drainage, because after all, this is what the symptoms are. Definitely treated as if it was a metastatic disease. Post-operatively, use the albendazole for, I don't know, you said 2 years, maybe 2 years, I don't have the answer, and follow up what's going to happen in this rectal location. Because you have this window, and I believe he's young, he can sustain an extended resection, he can have a very good optimum biliary drainage, and then I will treat him as an adjuvant therapy with albendazole, maybe for 2 years, as you said, and follow up mainly the rectal location, which I personally never seen. So this is my opinion.
And did somebody of you see extrahepatic locations in the abdomen? Do you know if it infiltrates the tube or not?
No, personally, I don't observe that.
Yeah.
Just a question.
I've seen it.
René, you have something? Yes.
Yes, just a question. I have a very little experience about this disease, but my question is, would you consider the extrahepatic spread as a contraindication to liver transplantation or not?
Personally, yes.
Yes.
Personally, no. No.
Pietro, no, because but if you may give it quite light immunosuppression and still having a good liver function, transplanted liver function, you may operate on the potentially recurrence outside the liver, or prolong the albendazole treatment that will slow the development of the disease. It's a young guy, so we have a lot to do.
Can I do a comment?
Laurence, yes.
Yes, I'm a little confused because what I saw in the slide of Valerio is that the peritoneal disease is very, very extended. There is scalloping all over the right liver, and all the peritoneal seeding down to the rectum. So it's not
Can you show us again?
Do you see it here?
No, there is a better view in another slide for the scalloping.
For the scalloping, yes.
The scalloping, because I think that all the disease is on the diaphragm. So my question is, what will you do? Because if you want, you will be R2, not R1 or 2. And my concern is after a resection, which will be very, very difficult, because there's the problem of the vena cava, there's the problem of the hilum, there is a biliary left colon and a rectum dissection or resection. This is a very heavy procedure. And what about after the disease? Because it's like neoplastic disease, and after it could be an extended, not recurrence, but progression of the peritoneal disease. This is a real concern. In my opinion, I would wait to see if albendazole can reduce the disease first, because it's not an emergency. As Pietro said, it is a very progressive but very slow disease, and I think that of course the stent is not forever, but the stent can be changed.
Sure.
Yeah.
And you think that with albendazole, in your experience, do you think that the albendazole can reduce the size of the mass, or
yes,
it just stabilized the situation?
Yes, I saw it, but I'm not sure in that type of echinococcus. I saw a very good response in other echinococcus, but not maybe. As Pietro said, I advise you to call Besançon, and they collected all very difficult cases. And when I have some case like that, I refer to them.
So Valerio is now working also in Geneva, so I can connect you with her if you wish.
Yeah, great. What's the name? It's who is the?
I sent you an email. It's Christian Dozo. I sent you an email.
It's Solange Bresson-Adny, but it's difficult. It's as difficult as echinococcus. Having said that, Laurence, what I've seen so far, but let's put ourselves in Solange's hands, is that the fibrosis is a problem with the disease, and albendazole stabilizes it, turns it off, but the strictures do not disappear. And the R0 resection are ideal, but in fact, we had, for instance, a transplant patient, Madame Cliva Christian, who had recurrent after transplantation, and she lived 10 years.
Where? Recurrence
after
where?
liver transplant. After liver transplant, in the liver.
Yes, in the liver.
Around, but also yes, in the peritoneum around. And
you would leave half of the disease in the patient. You would only be able to remove half of the disease with the price of a very...
But the problem, for me, the only problem of this patient is the stability of the biliary drainage for the next 40 years, which is my aim of survival.
But he won't survive 40 years with only a biliary drainage. It's impossible.
Exactly. This is why I think that once I get my biliary drainage secured for the next 40 years, I think that the rest I can manage, because you can stop the disease on and off with albendazole and monitoring with the PET CT. But let's say what Solange says and stop discussing about it because we've gained the edge of our knowledge.
Solange is a physician, she's not a surgeon.
Yes.
Yeah.
But she's
They have a team. It's a reference center, and they have a team with surgeons and physiologists and bacteriologists and so on.
I know. Now, one point in this patient, I think it is not a new disease. It's a long-lasting disease. When you look at the diffusion, extraperitoneal diffusion, to go from the liver to the rectum is a long duration of the disease. And on this point, I am a little afraid about the jaundice. If the patient jaundice, that means that the two biliary branches are taken by the disease. And I saw many cases at the beginning with diffusion along the bile duct inside the liver. I did the right liver resection, and then after the patient recurred, he died, and on autopsy, there was all along the bile duct inside the liver, there was spread of the parasites, small vesicle of the parasites were along for centimeter and centimeter. That means in this case, I am afraid that there is a diffusion inside the liver. And really, I don't know what to do in this patient. The stent, of course, to treat the jaundice, albendazole to treat the parasite, but I don't know how long it may start. It is advanced disease and not only a liver disease. It's already a little too diffuse.
Just an additional, sorry.
Yes, René, yes.
Just an additional advice to Valerio. Solange Adny-Bresson knows the disease very well as a physician, but the surgeon who had the higher experience in that is Georges Mention, which is retired, but you can be connected with him because he has operated a lot and transplanted a lot of patients like this. And the experience of a surgeon is also important to us.
Yes, I agree with you, René. Yes, sure. You may oui, Mention.
Valerio, Jean-Robert, I send you the cell phone of Georges.
Okay.
And I think it's a very good idea.
Okay.
Yes.
Okay.
Thank
so
you very much.
We stop. Thank you a lot, Valerio. Very technical case. Let we know later on about the issue in this patient.
Yes, I'll keep you informed what the team of Besançon advises.
Yeah. Valerio, John.
Thank you very much.
Thank you, Valerio. John.
Okay. Wait for. Good. Thank you. Can you see that, the presentation?
Not yet.
Not yet. Okay. Okay. It's sharing now?
Yes.
Is it sharing?
Yes.
Yeah.
Okay, good, great, thank you. Thank you, greetings from Birmingham. So I'm going to present this case. It's a very young man, 18-year-old. He presented to us a while back in November 2018. He came to the emergency department of another hospital, severe abdominal pain, radiating to shoulder. Had a history of a fall, which wasn't a very severe fall. Also had seizures at the time, which were self-limiting seizures. And the hospital shared with us some images here. So this is his initial CT. Obviously, you can see it's a very abnormal liver in this 18-year-old boy. We have a large lesion here in the left lateral section. Another lesion, as you'll see, is on the right lobe of the liver. We believe this lesion was bleeding, causing hemoperitoneum, and quite a significant hemoperitoneum, and he was transferred to us. So this is a screenshot in the early days of his liver function, a bit of an elevated transaminase. Bills were around 45, so elevated. He had maintained liver function, slight elevation on the INR. His albumin was okay, but you can see it's a little bit low. So there is probably evidence of chronic liver disease with an acute hemoperitoneum. So we transferred him over to our hospital. He remained stable, although he had fevers with raised CRP. The hemoperitoneum is a problem, it was causing a lot of pain. So it was drained. Young lad was treated with antibiotics, and he was then discharged for follow-up. So we looked at him in our MDT, and we noticed also this abnormal liver. He had basically an abnormal absent portal vein. I'll show you a few clicks here. He also has a very malrotated bowel. This is his SMV coming up and joining his splenic vein. I'll show you again. Splenic vein coming this way. This is his SMV. They join together. You form a very short common trunk. Then they proceed, the common trunk joins the left renal vein here, and there's no portal vein going up to the liver. Some arterial branches. One of our radiologists thought, after looking very carefully, very tiny sliver, but essentially there's no portal vein going up into this liver. So here's just a short movie that I'll show just to demonstrate this. Oops, sorry. Get it again. Ah, dear. Sorry. Okay. So this is his malrotated bowel over here. He has no transverse colon. The bowel is all on this side. Large bowel is on this side. These veins here are the mesenteric vein, the SMV, splenic veins over here. So the SMV coming across here, splenic vein over here, then joining into a common trunk, joining the left renal vein, going upwards. There's no portal vein. And these were the lesions that we were following. So this is basically an Abenati malformation. So, you know, just a quick summary, the type 1, when there's an end-to-side shunt, and a type 2, when there's a side-to-side shunt, which maintains flow into the liver. The type 1A, when there's separate drainage of the SMV and splenic vein, and type 1B, which we think this patient has, is the SMV and splenic vein join to form a short extrahepatic portal vein, and then they join the IVC. So, quick schematic, we feel SMV joining the splenic vein and joining the systemic circulation via the left renal vein. So we think he has a type 1B Abenati malformation. So this is young lad remained very well, really, and it was followed up by our physicians, hepatology team for a while, and he had a MRI about 6 months later. The MR shows the multiple lesions. This one here, this is the T2 on a Doterem MRI, is the T2 sequence. Shows this lesion here on the right lobe, segments 6 and 7. We've had evidence of bleeding, although it wasn't the primary lesion that bled. We have this large lesion here as well. As you can see these segment 2, 3 lesion, which eventually bled. Another lesion lower down in segment 4. Which is bright on the T2, showing a central scar, and we thought this probably was an FNH. It's the MRI, just report in summary. I'll skip through that. So that lesion in segment 4, this big one over here, we felt was growing, and this was biopsied. And this has come back, the well-differentiated hepatocellular lesion, probably an adenoma, and we think it's an inflammatory subtype of the adenoma. Okay. So again, this patient remained well on our watch. The segment 2 lesion, the one which eventually bled, was growing in size after this, although the patient remained well. As we know, at Abenati, they can have a number of other congenital malformations. He had a cardiac referral showing just mild mitral and tricuspid regurgitation. Because of the liver disease, we had a good look for portopulmonary hypertension that was negative. There were no pulmonary AVMs, no septal defects. I was just generally being worked up as a case of Abenati, and we decided we needed to biopsy the segment 2 lesion, which we did, and it showed just run through salient points, tissue relaxed, portal tracts, in keeping with an adenoma. There was of bile ducts, again, in keeping with an adenoma. Little evidence of atypia. In some areas, perhaps an increased nucleus cytoplasmic ratio. But as with many of these cases on biopsy, it was called a well-differentiated hepatocellular lesion, difficult to classify whether it's an adenoma or low-grade HCC. So are we dealing with an adenoma or low-grade HCC? So really, finally, we come to the present, which is just a short time ago when he had an updated CT scan. And these are the lesions again. This one, which we felt bled before, but remains stable, hasn't really changed very much. You can see the segment 2 lesion here. So we think this is an adenoma or an HCC. This we think is an FNH in the lower part of 4. This one here we think is an inflammatory adenoma. This is the worrying one we think might be an HCC. And here's the inflammatory adenoma. And this lesion, which has got hemosiderin, contains a bit of blood there. So we have a summary of these lesions in 2-3 to 76 mm. Probably could be an HCC, but stable. We have one FNH in the lower part of 4. We have an inflammatory adenoma in the upper part of 4, and another lesion on the right side in segment 6-7. Contains fat, remains stable. We're not sure what that is. So this is our management dilemma. So we have a 19-year-old patient, male patient with Abenati 1B, at least 4 lesions in the liver. The segment 4 is inflammatory adenoma, we think. Segment 2 lesions, possibly an HCC, previously ruptured. And we're not exactly sure how to proceed. He remains very well. We do feel that follow-up assessment of these lesions can be very difficult, and we're concerned about leaving a malignancy in this young patient. So I think we could probably open this up for discussion at this point in time.
Thank you. John, thank you. It's a very interesting case. Laurence, of course, I ask first to Laurence.
Yes, Laurence.
Hello, John. Yes, it is a really interesting case. And as a matter of fact, this syndrome is associated with a different type of hepatocytic lesions. It can be adenomatosis, of course, and you said it was inflammatory type, but there is also a lot of different type of hepatocytic lesion like FNH or pseudo-adenoma tumor. Anyway, this case is interesting because it's a man. It's an inflammatory adenoma, but you should see if it's beta-catenin positive or not, which is important to decide what to do with this liver. I think that it is very important to have a good diagnosis of those tumors. I think it could be an indication for transplantation, perhaps not now, but in the near future. So HTC is, of course, possible in this case, and maybe more than possible. It is probable. So if it is, I think that for that young man, transplantation is the option.
Mm-hmm.
I hope, of course, because you said it was ruptured. The second tooth was ruptured.
That's right.
So I think that it would be important to check if there is not peritoneal seeding. So as for me, I would operate him to check, and I think that transplantation, if it's possible, it's the best treatment. And the agenesis of the portal vein is not a contraindication because you can do a renal portal anastomosis.
Yeah.
So for me, it's what I think for this interesting case.
Okay.
Can I ask a question to Laurence?
Yeah.
Laurence, I've seen that patients, adults who had portal cable shunt in childhood, develop hepatocellular adenomas. Can you develop on that?
Yes, it's what I can say. It's easy to understand because it's an arterialized liver.
Absolutely.
So this is the genesis of adenoma, which is a difference in the balance between portal and arterial flow. And you can create adenomas doing that. And it's very interesting because those adenomas and even HCC happen in patients with splenorenal shunt in the childhood, surgically done, or agenesis like that. So, well, it's quite understandable because of the difference, the circulation, the arterial circulation in the liver.
I totally agree, because from the beginning I would have loved to see an angiogram the day he bled. I would have loved to see an angiogram, because that you will see that it was an arterial liver, and Abenati syndrome can create that sort of hypervascular lesion. And I agree totally with what has been mentioned before. I mean, he's on the pipeline of a liver transplantation. The consideration anyway of agenesia of the portal vein, you have to consider the hemi transposition technique like Renoport and etc. anastomosis, but he is on this path anyway, and this is definitely what you see in arterialized liver.
Can I ask Gina and Lawrence, with you? Are you worried obviously about the rupture that occurred slightly less than 2 years ago? And would you think that that might contraindicate transplantation, that 2-3 lesion is the one we suspect may be harboring an HCC? Is that a contraindication at this point in time to transplant?
No. For me, it's of course a concern, but it's not a contraindication at this age, of course, because I saw peritoneal seeding, which can be removed, and several times in the history of the patient. But that's why. Personally, I would have been a little more aggressive in this patient, even doing a cilioscopy or a peritoneal lavage toilet, you know, to see if there is seedings, and it would be interesting to do some a good biopsy of the liver, the normal liver, well, not tumoral liver, and the different tumors. Yeah, because very often, as you said, there is FNH, there is adenomas, there is regenerative nodules, a lot of different lesions. But if you have one adenoma, which is an HCC with a malignant transformation, it can happen in whole the liver. So that's why you have not to wait too long for this young patient.
Nothing. Can I make a comment?
Yeah.
Just
yes. So Laurence, and I have the feeling that it could be a good indication for transplantation. He's 18. He's 18-year-old. He has several complications with bleeding, and you say the risk of developing angioma, adenoma, or hepatocellular carcinoma. I think if you put in the balance the risk of liver transplantation on a normal liver, 18 years old, and the risk of the evolution of the disease, personally, I will go on the transplantation.
Yeah,
that was I said. I would have been a lot more aggressive.
I agree. Yes.
Just another comment. This year we published 2 cases of Abenati. One of them was transplanted, and I also agree with the option of liver transplantation. All our 2 cases were also connected to HCC. The only thing I would comment is that in this type 1B, you have a common trunk going to the IVC of the left renal vein. You don't need a renal portal anastomosis. What I did, I transplanted that patient, for example. You can disconnect it from the renal vein and just put it directly in the portal vein, which
Right.
is...
Hugo, I think that it's a lot easier here to do a renal portal anastomosis because the trunk is very deep in the pancreas, I think. So it will be easier to do a renal portal because there is a real good splenorenal anastomosis.
Yeah.
Could be.
Yeah, transposition with renal port. Yeah.
So
you are so good, Hugo. So good.
Yes.
Yeah.
For people who are less good, when you do a renal portal anastomosis, take a big chunk of vena cava and do the suture on the vena cava rather than the renal vein.
Yeah, so that's the renal vein there, and take it up. Yeah, we were quite excited by the prospect of transplanting this patient and thinking about using a renal portal anastomosis, and equally concerned about the HCC developing and complications of a failing liver in a very young boy. So we brought it to our MDT basically, and exactly with these questions. So enlarging lesion with Abenati, difficult to interpret, histology, and difficulty in following further lesions. So we wanted a liver transplant, but in the UK, he didn't meet the criteria for immediate listing. So we had to take it to the National Appeals Committee for a decision, where we would put the case before all the liver transplant units. And the response came to us is not for listing immediately because the segment 2 lesion, if it's an HCC, it's beyond criteria in the UK, being 7 centimeters. And the history of the lesional rupture would disqualify him because less than 2 years. So their recommendation to us would be to hold on transplant, think about resecting the segment 2 lesion, or even doing a TACE. So we were really stuck. We could not transplant this patient. So we felt as a holding pattern, we would like to resect that segment 2-3 lesion, have a good look at the peritoneum as well, see if there is any seeding. Interestingly, we did a workup. In the absence of a portal vein, we did a gradient anyway, which we thought would be interesting to know about. The gradient was quite high. I'm not really sure how to make sense of that in the absence of a portal vein, but hepatic venous pressure gradient was 22. And we then took him for an operation, which was just done a few days ago, to take the segment 2-3 lesion. It was a very straightforward operation. The lesion was removed without difficulty at all. What we call a registrar case over here. No evidence of any spread in the peritoneum. We have initial histology. It's a well-differentiated, again, HCC versus adenoma. We're waiting the reticulin stains and the immunochemistry. On the path of this big lesion, it looks like an adenoma. It's pretty well differentiated columns of hepatocytes. You can see an artery here, unaccompanied artery, indicating there's an absence of a portal tract, absence of biliary radicals. It looks like an adenoma, but we're waiting for further histology to see whether it's an HCC. And our plan really is to put this forward as soon as he recovers from this with the new information, again, to the appeals committee for transplantation.
John, on the histology of the specimen, do you have the result of the non-tumoral liver?
Yeah, we're waiting, Gina. We're waiting for that. It was taken off with a reasonable sliver of non-lesional liver, and we will get that and report back. We're also very interested in that. And it was actually just done on Monday last, so it's just been a few days. So we'll have to wait for that.
But you have to add, as Laurent says, do the catepsin test, and etc., just to add more in the balance for pushing for transplantation. Because because in the panel, and I've been there and you know it very well, you have to add as much as you can as information. This is regardless of the lesion, this is an arterialized liver. You have a portal hypertension. Whatever they will say, at 18-year-old, he may have a lot of complication and even bleeding in the future. And this is the time for transplanting this patient.
Yeah.
You have this in your bag.
John, please.
I'm sorry. I am very disappointed by the answer of the committee.
Yeah.
The first reason I think is not valuable, for it is not a cirrhotic liver, and the contraindication is coming from cirrhotic liver. It's not a cirrhotic liver. As you know, we may transplant patients with very large hepatocellular carcinoma in liver, in non-cirrhotic liver. That means the point one, I don't accept. And the second point is also controversial. So I disagree with this answer. And I think
the rupture, I think, was one of the
rupture is not the rupture of the tumor; it's the rupture of the adenoma. So
I think so. If we can prove this is an adenoma now
together.
Excuse me. Can I comment? Can I comment?
Yes.
I'm not surprised by the decision of the panel because your case is not enough illustrated. I mean, we don't know exactly what is the disease in the liver. If you suppose that it is an adenoma, if it's an adenoma in the left lobe, it's resectable, so it's no need of transplantation. What you need to prove is that there is either hepatocellular carcinoma in whole liver or very dangerous adenoma because it can be malignant in the future. So my question is have you the opportunity of doing during the surgery biopsy of the other tumors in the right liver? Because if you prove with biopsy that you have a beta-catenin adenoma in the right liver not resectable, it will be an indication for liver transplantation. Because I repeat, I'm not surprised by the decision of the panel if you have not proven that it is a dangerous adenoma or HCC.
That's right.
But Laurence, this patient is today in your center in Bordeaux.
Yeah.
What you will do?
I would have done a resection of the left extrahepatic large tumor to analyze it and to see if it's an adenoma, if it's a beta-catenin adenoma, or if it's an HCC, and of course check the peritoneal seeding if it's there. And after during the operation, I would have done a lot of biopsy of the liver, because this is the right indication to prove that it is a liver that can become a multiple HCC in the future. As you are completely right, Professor Bismuth, and it's very, very disturbing that all those panels mix the Milan criteria in not cirrhotic liver. It's not the point, of course, but concerning the indication of liver transplantation in hepatocellular carcinoma in non-cirrhotic liver, you have to prove that it's not resectable. So you have to prove that this patient is not resectable.
Yeah.
Yeah, but I think sometimes it is so complicated.
I have a technical question. To John. Has a patient portal hypertension? And if so, is there any spontaneous porta-caval shunt or not?
Yes.
Well, I think he does not, as far as we know, René. I think he's got a fantastic natural porta-caval shunt. and he's demonstrating no clinical portal hypertension in terms of varices. And obviously, you know, no problem with hypersplenism or anything like that.
Mm-hmm.
So he's behaving like a very well shunted patient, so no portal hypertension.
Okay. No, because my question was about the renal portal shunt, because really, I think it's not so physiological to have, I would say, a renal portal anastomosis. And I would say the alternative would be to make a jump graft to the mesenteric vein in a way to have a much better physiological, I would say, portal perfusion of the liver.
Mm-hmm.
But this is justified when you have a portal hypertension without shunt. It
Right.
would mean that you have to close, I would say, the connection of the venous of the superior venous vein to the caval vein.
That's right. I think, as Hugo said, our hope is to use that short, common trunk and use that for the portal inflow when we eventually transplant.
I would prefer to do this.
Yes, and I would say that a jump graft is usually much more difficult than that, I think.
I think Lawrence's advice that we'll take back, we'll get the full histology of this lesion and we'll get the native liver histology. I think we can make a very strong case now, especially this lesion we've removed as an adenoma, it's not an HCC. There'll be no contraindication to transplant, and I'm sure we get approval for that.
Okay, John, thank you a lot, and let us know in the future about the issue of this patient.
Sure, yeah.
Now we go to Pietro. You have a case.
Yep, it's a very quick case. Yep.
Okay, go on.
And
it's after
a quick
René,
case.
René, you too after. Okay.
Yeah, it's a quick case, and I wanted to have the advice of the more expert pancreatic surgeons. The peculiar thing was that the mother was diagnosed with advanced pancreatic adenocarcinoma, metastatic, 3 weeks ago. And the GP did a CT scan in the daughter, who is 55, and or 50 in fact. And we found an advanced pancreatic adenocarcinoma with this configuration. She has I show you. I present, just a second, please. Can I, tell me if you see my screen. Yep. And it's coming. Can you see?
Yes.
Yeah.
Right. So it's just the CTs I have now. This is a portal time on a sagittal. She had occlusion of the portal vein about 2 centimeters from the tumor, and I show you the tumor on this. Can you see it going?
Mm-hmm.
So this is a tumor. Portal mesenteric vein disappears there, just below the splenic, and reappears here.
Yeah.
So it's about 2 centimeters, the gap. And she has, and I show you on this, three hepatic arteries, a right, a middle, and a left. And the right is running extremely close to the tumor. And she's got a middle and a left. The left is probably rather small, vascularizing only one segment, I think. Right, and my question to the most experts is what to do with the right hepatic artery, whether I can simply cut it, and if what you do now for this gap in the portal vein, provided the patient will go for chemotherapy for 3 months.
Okay.
Yeah.
Okay, thank you,
Pietro, may I comment?
Go.
In fact, I wanted your comment, Jean-Robert, but I want everybody else's comment.
No, first, the problem is not the vein. The problem is the superior mesenteric artery, because you have a circumferential invasion of the vein. So the problem is the SMA and not the vein. This is the first point. The second point is about the right hepatic artery. You can embolize the right hepatic artery without any problem. Intrahepatic shunt developed in probably immediately after the embolization. So the problem usually we wait SMA 8 to 15 days before going to surgery. This is the first point. The second point now the patients go to chemo, right hepatic artery. So chemo first, FOLFIRINOX, and then
you finish.
Reevaluation, and perhaps radiochemo. And after the sequence, chemo and then radiochemo, with a good reevaluation, composing CT, hepatic MRI, you can perhaps do a secondary resection with an hope of R0 resection, hoping that the medical treatment is going okay. And before the resection and the reconstruction of the portal vein, you have to do a biopsy of the arterial sheet, because if the arterial sheet is positive, it's an absolute contraindication to resection. This is my opinion. And Pietro, I have just a question. What about the CA99 level now?
Not yet. I saw the patient yesterday.
Okay. This is a very important information.
She's not jaundiced.
Okay, because
she's not jaundiced.
The tumor is far from the biliary tract. Huh? It's quite a tumor.
So it would be irrelevant. What I'm saying, it would be a relevant CA19-9 level because it's not being contaminated by the jaundice.
Yeah.
Okay.
Can I comment?
Yep.
Pietro, I think that I agree with Jean-Robert. It's non-resectable. For the moment, it's not resectable because I saw invasion of the gain of the mesenteric artery. And it's often the case when there is a complete occlusion of the portal vein. But I think that it's mandatory to have FOLFIRINOX and radiotherapy on this gain of the mesenteric. We are proceeding in a publication with Jean-Robert with this embolization of the right hepatic artery with very good results. We collected more than 15 cases, and it's very effective, and it's better for R0 resection. But I want to ask Jean-Robert and all the companions if they are aware of the paper of Marc Trouty of the Mayo Clinic. I saw the work, and I spoke with him. It's a very, very interesting approach because he said that the arterial problem can be solved by very extensive surgery. As we know in France, this is a taboo because arterial resection is, well, quite forbidden. But he showed us more than 200 cases of resection of the arterial mesenteric artery and celiac trunk, doing like what we do for Appleby, modified Appleby surgery. And it was really, really amazing, because he has a very, very good results with this extensive surgery, with a very aggressive approach, because he the main problem is to have CA99 completely zero. He has to do a PET scan. If the PET scan is negative after chemotherapy, those patients are eligible for resection. And when these conditions are completely okay, he can have very, very good results. So I thought that he published that, Mark Truty, and it's very, very interesting in those cases.
Yeah. Can you send me the reference, Laurence? I missed the paper.
Of course, of course.
Yes, Laurence, I read this paper. It's very interesting. And sometimes we have, in France, a paradoxal attitude, because we do Appleby resection after response to neoadjuvant treatment, but we don't do SMA resection. Why? Because usually the extension around the SMA for pancreatic head cancer seems to be a metastatic disease. And the problem is we don't have any prospective randomized study in the same patient with very good response, normalization of the CA99, and medical treatment versus surgery. And this is a huge concern, because if you look to our experience in my institution, the median survival of the patient with such results, good response, very good response to the treatment, normalization of CA99, no surgery, the median survival is 28 months. 28 months of median survival with medical treatment. So when you look to the quality of life after SMA resection, this is a very important problem, because the quality of life, it's my opinion, the quality of life after an extended resection of the superior mesenteric artery is very bad. And if you look to the experience of Heidelberg, Thilo Ackert had published relatively recently in HPB, had published the experience of Heidelberg. Due to the mortality rate and the morbidity, now they don't resect the superior mesenteric artery. They continue to do Appleby. This is quite paradoxal, but they continue, but they don't do SMA resection because they have.
Jean-Robert, I am aware of that. And that's why I wrote to Truty, and I had a very interesting conversation with him, because he said that he had a team for nutritional and post-operative management of those patients. And of course, they selected the patient very well, normalization of CA99, negativity of PET scan, and excellent response to chemotherapy. And I was aware of that problem of quality of life, but he said that he improved his results with the very aggressive management of those patients in pre and post-operative period. This is I don't know, because the presentation he made was really interesting, because it was totally different in the concept. He began his talk saying that the problem is not the artery but the vein. When the vein is not possible to reconstruct, it is impossible, but the artery are not anymore a real problem. And
that's a paradigm shift.
yes, absolutely, absolutely. But I really believe in that selection of patient. I think that for your patient, if she does not respond to chemotherapy and radiotherapy, it's not worthy resecting her.
Yeah, but I mean, she's exactly the kind of patient on which you would try, because she's 50, three small children. I mean, 28 months for her would be nothing. She's more all or nothing approach in this case.
Can I have it's a question. I mean, there is the problem of technicality, and there is the problem of what's the outcome. I don't have the answer, but I would love to know what is it your approach, because if the outcome is going to be good or bad, do we know? Do we have that sort of answers in that type of a tumor or the case that you've presented, or not? Does it worth to go ahead for this aggressive approach? Do we have enough follow-up about this patient to see, let's go for it or not? I don't know. I'm asking because I've heard interesting proposal, even with the paper that Laurence has mentioned, but what is the long-term outcome of this patient? Does it worth it? This is what I want to know.
The Truti present his cases, I repeat, 200, and the mortality now, these 10 last years, are 4% for extensive resection, and 60% at 5 years, 60% at 5 years if all the conditions are gathered.
Met.
Okay.
Okay. Good.
Yeah. I will really need to send you all the details of the case, Laurence and Jean-Robert.
Yes, okay.
So that you can advise, and I will operate her with Christian if we come to that time.
Okay. René, thank you, Pietro. René, are you ready?
Yes, I think. I don't know. You can. I can share my screen. I don't know if this is done automatically or not. What should I do exactly?
Christian, you have a case after.
Yes.
Yes.
Okay. After René is Christian.
You see my screen or not?
No. René, you have to share. Click on Présenter maintenant.
Present now, yeah.
You have to click on
Présenter maintenant. Present now.
Present now, but where?
You have it on the bar, underneath, on the bar.
Down.
En bas à droite. En bas à droite dans l'écran.
Présenter maintenant. Okay.
Voilà.
Very good. Okay. Have you my screen or not?
And you have to confirm by clicking share again.
Okay. Présenter maintenant. Again. Intégralité de votre écran. Autorisé. It's okay. You have it. As you have seen, I have not only the name, but also the surname of my delicious wife. In the past, the men were given their name to their wife. Now it's not only we have reverse, but now I take her surname also, you know. Anyway, so it's a case, very classical case. It's not something very new. Anyway, I'm sorry I put it in. It is in French, but because I was assuming that we will speak in French. Anyway, so it's a patient 64 with a history of breast cancer, but it was in 2002, so 18 years ago, and she begins the disease with pain, hypochondrium, with transaminase elevated, with cholestasis, and very high tumor markers. And a CT scan was done that you see here, okay, with a multinodular liver, with all the segment of the liver totally involved by tumor. And of course, my first question is, what would you propose as a further exploration? Do you would advise any biopsy of one tumor? I know that the attitude between teams may differ. Some teams may ask for immediately for a biopsy of one of the tumor to have a diagnosis, and other, and I'm part of this order, not to do any biopsy of the liver, but to do upper endoscopy and colonoscopy. Anyway, so I don't make any survey to go fast. The patient was treated elsewhere, and a biopsy was done, revealing an adenocarcinoma, probably from colorectal origin, but the coloscopy confirmed a cancer of the left flexure of the colon, but it was not in occlusion. And the biopsy confirmed the adenocarcinoma, showing that finally the hepatic biopsy was not useful in the strategy of this treatment. CT scan of the lung was also done and revealed some micronodular lesion, very, very suggestive of metastasis of the lung. And so at the total, we were faced with a 64 years old woman with a history of breast cancer and a discovery of colic cancer with synchronous metastatic localization in the liver, in the lung, synchronous. And so my question to you is, how do you consider this patient? Resectable, certainly not, I'm sure, but initially non-resectable, but potentially resectable, or definitely non-resectable. The question comes from the fact that if we consider this patient definitely non-resectable, at that time, there is no place for surgery. So I don't know, I prefer to stop here, I would say, the case in a way to have what would be your opinion of such type of patient? I can come back to the initial CT scan. This CT scan, I say you frankly, is a CT scan done after 3 courses of chemo. So the initial CT scan was still more invaded. So any very quick opinion about, is there any place for surgery in this type of patient?
René, can I comment on this? I think it's a good idea to have done the biopsy, specifically because sometimes the mutations in the metastasis are different from that in the primary. So the mutations need to be done in the metastasis to direct the very good aggressive chemotherapy. And today we would probably classify this as potentially resectable and have a look after chemotherapy.
Okay, so
can I also comment? I would say, for example, in this case, we wouldn't think of a transplantation because of the pulmonary disease, but and I would say also that we couldn't do a real R0 resection, even with a very good response, but maybe with an excellent response, this could be a case for a sort of debulking resection later on. I wouldn't consider it totally unresectable.
I fully agree with the comment of Hugo. I think all the segments of the liver are involved by the tumor. And so in my view, this patient could be considered as definitely non-resectable by a partial hepatectomy, even with a very good response to chemo. Any other comments?
No, only to answer to John. John, I think 40 years ago, a surgeon from your country said there is no indication of surgery when there is more than 2 liver metastases. It was, of course, 40 years ago. You see the change in time in the same country.
Yeah, I think we appreciate that comment. I mean, the change has been very dramatic. Honestly, the question that we face sometimes is these patients never get referred because the primary units think it's unresectable, so they don't send to the tertiary centers. So the message we're getting out is that nearly always we must consider potentially resectable, which will help inform the decision on the kind of chemotherapy they get. Otherwise, they will just be treated palliatively.
John, I partially disagree with your opinion. Why? Because in fact, when we do a biopsy of any tumor, we take always a risk of a spread. Mm-hmm. And some papers have shown that those patients that has been biopsied before surgery had an outcome which is less optimal compared to that of patient without any biopsy. And the other point is that it's important what you say, but in 90% of the patient, there is a correlation between the primary and the metastatic process concerning the relationship between the mutation between the primary and the liver metastasis. So the interest to do a biopsy for me is very, very small.
Yeah, Rennie, I completely agree with you. We would never biopsy routinely, but I thought as the biopsy was done, we would take advantage of that to look at the mutations. But we would never do that routinely. I agree.
Okay. So this patient had, as expected, chemotherapy with Volfox, cetuximab during 6 months, and after 8 courses of chemo, you have here a very, very good response to this treatment, okay, with some very, very important missing metastasis. Here you have also a very, very good response. And anyway, at the MRI, we have still persistent tumor that is seen much better than on the CT scan, also in a diffusion MRI. And on the PET-CT, you have here lesions that are a very high uptake and predominantly in the left liver, but right, we have also persistent uptake, metabolism uptake at the PET-FDG. So in summary, very good response, more than 50%. The pulmonary nodule has disappeared, suggesting retrospectively that they were metastatic. Still hypermetabolism uptake at the PET-CT, predominantly at the left, normalization of the tumor markers, and the colonoscopy was done again, and there was no abnormality. So what to do? I stop here again the case. What would you consider in this type of patient?
Just, René, one question first. The colonic lesion has been resected or not?
No. He's in place.
It is still in place.
Still in place.
Oh, okay. Why they haven't resected the colonic lesion? This is my question. First question.
Because
the primary.
It's not classical to resect a tumor which is asymptomatic, non-occlusive, in the presence of multiple liver lesion. So it's now, in my view, it's the classical attitude not to resect the primary when it is not symptomatic.
Okay, but in that case, is it the question to treat the metastasis and leave the primary in place, or to treat the disease entirely? Because in this case, surely with this good response of chemotherapy, it means that the day you're going to stop the chemotherapy, I think, and I'm sure, it will reappear. It will reappear. So the disease is not treated completely. You cannot avoid a micro nodule which is active. So the patient is good under chemotherapy, but you're not going to keep that forever. So it is a question of two things. Either I consider that I need to treat this patient. So in that case, I consider a very aggressive approach, or I consider this patient non-resectable, and then I will leave it for chemotherapy stop on and off. So
but this is my question, Gina. What would you do?
in my case,
René, may I propose something?
Yes.
As there is an excellent answer to the chemotherapy, if we are a little optimistic, personally, I will propose to do resection of all the segments invaded. That means the 8 segment.
Yes, I see. I follow you.
Exactly.
Plus the colon, of course. Plus the colon.
Plus the colon. I mean, this is where we had.
No. So you propose transplantation, but
plus the lung.
Plus the lung.
No.
ICC.
No, but considering that there is an excellent answer to the chemotherapy, there are 2 solutions. Or we continue the chemotherapy, but until one moment, or we consider to do. But this is very aggressive, aggressive.
Yes,
but we must be optimistic.
But we can consider that the lung metastases are a contraindication, are a recognized contraindication today to transplantation. This is my view, but some of you can comment something different.
Were they bilateral or not? I mean, I haven't seen on the lung where they are, the lesions. Are they resectable in the lung or not? I haven't seen.
I think there is a possibility of resectability.
Okay. So in that case, you may consider, if you want to have the aggressive approach, I will do laparoscopic resection of the lung as well as the colon, and then second step, consider transplantation of the liver. This is the aggressive approach.
René, can you see any way of resecting, doing a partial resection of the liver, only of the lesions that you are identifying right now, and then wait for a further recurrence to consider transplantation?
Sorry, I didn't catch your question. Please, could you repeat?
I was thinking about the possibility of trying to resect the lesions that you see now after the disappearance of chemotherapy, and the lung and the colon, and then wait a little bit and keep transplantation for a second phase.
Yes, yes. A two-stage transplantation is your proposal. Why not?
No, René, I come back to my proposal. I think that sometimes in surgery we have to cross the frontier and to go to some unknown territory.
Okay.
Of course, not to be. I think if this patient in a good situation, you said there is a chance that the lung tumor may be resected. The colon, of course, is resectable. There is no other extrahepatic disease known. So why not to dare to do that? But as I said, at that time, we cross the frontier to go to the unknown. For we are in the unknown totally.
Okay, so if you want, I will advance. So we tried, we choose the fact because contraindication to transplantation, we choose the possibility in this patient to do a sort of debulking surgery. The rationale for that was that it was almost a liver-only patient with very small lung metastasis, with excellent response to chemo. And we are running, we are running a pilot study about exploring such type of debulking surgery in patients, strong responders to chemotherapy. So we did a left hepatectomy by laparotomy, multiple resection on the right with radiofrequency of deep lesion, also coagulation of superficial lesion, knowing that we assumed that it was impossible to cure this patient, but the objective was to prolong the survival. And here, the liver, which is not very lovely liver, but it was like this, okay? So, and you have also the effect of the chemotherapy, and so we did, we remove and we treat by radiofrequency all the lesions that were detectable by palpation, de visu, and also at ultrasound examination. And this is the specimen of the left hepatectomy. And interestingly, the pathological findings, 17 tumors, but without any carcinomatous cells. So total histological response. It was the case also because we did a lymphadenectomy. It was also the case of a big lymph node of the celiac region, who didn't contain any more cells. And finally, it was R1 for one of the lesion and satisfactory one. So this was the CT scan just before the operation, okay, with this is radiofrequency treatment of some deep lesion. We continue by doing FOLFIRI-Erbitux in a sort of adjuvant, not adjuvant because the primary is still in place and we have also lung metastasis, but anyway, and we observe no recurrence in the liver, normal tumor markers, and the colonoscopy. We did another colonoscopy to this patient, and the endoscopy said, "I don't find anything in the colon, possibly a small scare," and he put a clip on it. But my question to you is: we have a patient with a total metastasis on the liver. The colonoscopy is normal, with only a small scare, with a biopsy which was negative. I add something which is important, a biopsy which was negative. So what would you do for the primary?
René,
yes.
just a comment. I have a patient, the liver extension was not as huge as your patient, but it was quite the same. And the primary tumor never reappears, and the follow-up is more than 5 years.
Fantastic.
And I think that when you have, and we have the same histopathological response on the liver metastasis, no tumor on the specimen. And probably the primary is sterilized, probably.
Okay.
So what is now the benefit of a secondary colectomy? Probably no benefit now.
Okay, other opinions? Thank you. Thank
Can
you,
I ask
Jean-Robert.
you, René, please? René, could I ask you?
Yes.
When you say the colonoscopy is normal, did you mean that they tattooed the first lesion, and when they had another look after the chemotherapy, there wasn't any lesion by naked eye and biopsy? Is that what you meant when you say no anomaly?
Yes, it was not the same endoscopist,
Yeah.
but the second endoscopist that our center said, I don't see any tumor. I see only possibly a small scare. I did a biopsy, and the biopsy is negative. So I don't know what you would choose to do.
René, just one thing. I mean, my only problem with these cases, because we've seen that before, and you remember as well, the whole problem is how long are you going to continue the chemotherapy? Because the day you will stop the chemotherapy, whatever you do, you will have again reappearance of the malignant cell. I'm not sure that you have a sterilization of all the foyer of the cancerous cells. And the only problem here is if you started, I believe in debulking surgery, but if you want to have the aggressive approach, you have to go forward, meaning, well, I go in my strategy of resection, I will go to resect the portion of the left colon. This is not a big operation itself. The second step, it's also, I would have resected the lesion in the lung. Then I will go to this protocol of adjuvant chemotherapy for maybe 6 months and see what happened. I mean, this is my belief. But here you have the typical situation where we know that the new drug with chemotherapy disappeared the lesions, but unfortunately, when you're going to stop, it will reappear. This is my...
Okay, thank you. So we advance. In fact, we had a big discussion at our staff with some who argue for doing a colectomy, the other no interest of doing colectomy. And I contact the colorectal surgeon and so on. And finally, we decided to do the colectomy because we have a deep involvement in the treatment of this patient in terms of chemotherapy, in terms of liver surgery. And we said it would be a pity not to make a total treatment of the lesion. And finally, we were right, because there were a micro foyer, tumoral foyer in the colon. You can see carcinomatose was still present. And so we were right to do the colectomy, because if not, probably we will have a reappraisal of such type of tumor. And just to make a comment, I'm interested by what was said by Jean-Robert about the fact that sometimes we have a complete response in the different site. What I can say you is that in my experience, every time we may have a different response according to site. I have seen complete response on the liver without complete response in the lung. I have seen complete response in the primary without complete response in the liver. So I think we cannot give a global recommendation, and our aim should be to resect as much as possible all the metastases. And so this patient has been followed during 3 years without recurrence, and very recently she recurred. She recurred with a still normal CEA, single nodule of segment 5, very, very isolated recurrence with a small elevation of the CEA. And you have here the lesion, a debate, and here on also on because of course with the top lesion that had the patient, we fear that other lesion may appear. And I was in fact in favor of operating up front this patient without any chemo, because she has stopped chemo since 2 years. And so, but the staff said me, it's a patient with multinodular disease. 1 lesion is appearing now, but in 3 months, it is possible that 5, 6 lesions reappear. So please do chemotherapy. And they convinced me. So I did FOLFOX anyway. And the patient was resected with, the response was not so high to FOLFOX again. But anyway, and I did very recently, it was this week, I did 5-segmentectomy by laparotomy, not finding any other tumor in this patient. And so at the total, 67, adenocarcinoma, good response, double king surgery, complete histological response in the liver and lung and lymph node. However, persistence of the tumor in the colon, now a single recurrence. And for me, the message of this case is that debulking surgery could bring possibly a benefit in survival in patients with a very, very good response to chemo. We should do our best to resect all the tumor sites, even in case of total histological response of one of them. Our pilot study count now for around 15 patients, but the follow-up is too short to take any conclusion. But these patients like this are interesting to explore. And anyway, I think after this pilot study, we will need a scientific validation, and we plan to submit a randomized study comparing in these patients, very good responders, chemo plus debulking surgery to chemo alone, and this will be submitted very, very quickly.
So, okay. Thank you, René. Thank you. It's a fascinating case. I think it's not finished. You will continue by palliation, you know, recurrency and palliative treatment, but life is palliation.
Sure.
So continue. After 20 years of palliation, this patient, she will die of natural death, perhaps.
It's the objective.
Yes.
When the patient dies of something else, I will obtain my goal.
Thank you. He's good. Now, who is speaking now? Is Christian? Christian.
Yes, so I will ask Graziano Oldani, who has been promoted as staff in Geneva, who's a skillful clinician and a smart scientist, to present the case.
Only one question. Jean-Robert, do you have a case to present?
I've already started sharing the screen. So, can you hear me?
Yes.
Okay, so this is not a fancy case. It is interesting more for a story behind the case. So it was a case that slipped under our radar because it was presented to us just 10 days ago. But the story starts more than a year ago. A 74-year-old gentleman, ASA3 due to AF on anticoagulation and type 2 diabetes, non-insulin needing. He was found on January 2019 with a large rectal mass at 9 centimeters from the anal verge. It was staged T3 and 1 in close proximity to the prostate here. He also had 6 liver lesions, as you can see there, mainly located on the right liver, and 1 small lesion on segment 1, which is here. So based on that, and only on that, he was deemed non-resectable and palliative in a community hospital. So it was never presented to us. He was treated with 7 cycles of FOLFIRINOX and PGFE inhibitor, and he also had a short course of Xeloda and radiotherapy with a good response. We don't have all the files for that. But anyway, more or less 6 to 8 months later, he recurred. You can see the recurrence here, and he had a PET-CT showing mostly captation on the rectal side, but I don't know exactly what they did in a month, but he was presented at first to our colorectal surgeons because he was bleeding from the mass. So in that situation, he underwent a laparoscopic abdominoperineal amputation. That was in August 2020, right now, at the beginning of the month. And again, the pathology was a T3 and 2, and unfortunately R1 because of the radial margin, which was inferior to 0.1 centimeter. Of note, since he was deemed unresectable by physicians outside the hospital, and in that case, it came just to our attention when he was bleeding, our surgeon didn't resect the prostate. So the R1 margin was more on the prostate side. So what's the situation now, 20th of August? He had chemotherapy, but he had a good response to all the metastases that reduced inside, all of them. They're still there, the 6 of them, nothing on the left side, nothing outside the liver. So that was the evolution for all nodules that well responded to chemotherapy, a large window without chemotherapy. And it is an operable patient from the anesthesia point of view because he's very well recovered from the surgery he had no more than 3 weeks ago. So how would you proceed now?
How old is he?
He's 74.
Sorry?
74.
We have to operate him, clearly.
Exactly, straightforward with no other extra chemotherapy in between, or
No, because I think he received a lot of chemotherapy. Maybe it's a good window, and then you may consider adjuvant chemotherapy after that.
Yeah.
I mean, it's a possibility. That's what I would consider eventually.
I mean, he's been 8 months free chemotherapy, so you have a good handle on the biology of the disease in the liver. And it's resectable now. We should go straight for resection, I think.
That's what I said.
Yeah, exactly. That's the plan that we had, and what we were thinking about mostly was like resection of all these, except probably this one, that we benefit of the preoperative radioablation, and probably this one we would definitely probably go for a wedge, but it's also considerable for RFA.
How would the panel go? What type of surgery would you do in such a patient?
I think there is some argument for, I would say, a right hepatectomy because, of course, 6 nodules. I would accept the challenge of doing a parenchymal preserving hepatectomy with radiofrequency and so on. But I would say when you have 6 lesions on the right liver, it may be that we miss 2, 3, 5 others. And so I would be in favor of doing a right hepatectomy. It's not, I would say, my usual approach, but having 6 lesions with such type of, I would say, time interval without chemo and so on, I will give the patient the maximum chance of to be cured.
And I would do portal vein embolization. He's got a very small left liver, and he has had a lot of chemo. I don't see the size of a spleen.
Christian, I would go to wedge resections and radiofrequency. They are all small lesions. And if he recurs in the left liver in the future, you will be blocked if you do now a right hepatectomy. So I would go to parenchyma sparing surgery instead of major hepatectomy. Definitely.
My preference is like René, right hepatectomy, because you have already 6 lesions, maybe you have more. And also portal vein embolization, definitely, because of the underlying liver with chemotherapy. That's my approach.
Another point will be also to see the lesion, because they are very, very small, which is, I agree, an argument to say radiofrequency may be efficient, but which is also an inconvenience to detect intraoperatively, because if you miss one, it's a pity.
Yes, that's true, but you have to think also this patient is chemo-free since 8 months with roughly a stable disease, with all very small lesions. Probably you have to do an ultrasound before, perhaps, to see if they are well seen on ultrasound, and you'll have the answer.
No, I agree. It's totally defendable to try to propose what you propose.
I think whichever you're more comfortable with, and probably there is not yet right or wrong. Ideally, parenchyma sparing is better, but I'm afraid it will be, in theory, better. In practice, you're going to leave stuff behind.
stuff not visible right now, you mean?
No, I wouldn't worry about the not visible right now. But because he's been 8 months chemo-free, then the probability of waking up in the left liver are just as smaller. I mean, whichever. I mean, we can discuss for hours on that.
But if he recurs in the right liver, it's not a big deal. You then do a right
Valerio,
hepatectomy.
you're right. You're right. But in practice, it will be a very difficult and possibly incomplete clearance of the right lobe.
He is 74. He is 74, so I consider the age. So that's why I will go for maybe more radical resection with adjuvant chemo after.
He's 74, but he's not the fittest 74-year-old patient that we saw. So he's not hyper.
But I don't agree on adjuvant chemo.
So why
not? He's 8 months chemo-free. There is no point to do adjuvant chemo.
The adjuvant will depend on the pathology. The adjuvant will depend on the pathology of the specimen. And if he is not a fit 74, that's what I would say. I mean, probably consider protein embolization, because I agree that the left lobe is very small. I will probably even consider laparoscopic standard white hepatectomy to save the post-op length in hospital. And depending on the result, let's see what happens. But that will be my favorable approach.
Just a question. Why don't you consider chemoembolization in his case, since he's a high-risk patient?
It's colorectal liver mets. Chemoembolization do not work on colorectal.
If he's high risk and he's ASA-free.
No, but he's still...
Just a thought.
The surgery...
It's still operable.
Another question. I don't know if the patient probably he has a previous ultrasound, but I think that if you can see those lesions well in the, I would go for isolated resections rather than a major hepatectomy. I think the problem is always whether if we can find them or not intraoperatively.
Yeah, that's something we definitively need to do. Okay.
Okay, Christian?
Thank you.
Okay. I think we have another case from Jean-Robert. Jean-Robert Del Piro is here. No? I think he was there.
Yes, he's here.
Jean-Robert, do you have a case to present? You told me you have a case.
No, I have a case for the next meeting because it's a complex biliary problem.
Okay. So no other case to present today? No? I forgot nothing? If not, I think we finished the session. Thank you, all of you. And I think that we discussed this with some of you. Our next staff des Compagnons, will be next month, at the end of the month, exactly the Saturday, 31st of October. So be ready for this date. And thank you, all of you, for this excellent session. Thank you. And bye-bye.
Thank you.
Thank you very much.
Bye-bye.
Look at your mail. Goodbye. Look at your mail for the...
Okay, merci Jean-Robert.
I send the phone.
Merci.
Goodbye.
Hey, Laurence. Robert, Laurence et Christian, I will send you the DICOM of my patient.
With pleasure. Okay.
Thank you very much to the three of you.
I remind you one thing. I remind you that next week there will be the Congress of the French Association of Surgery, and Laurent Schiss is the president of the Congress this year.
Yes, and unfortunately, Laurence is the president. I'm an invited guest.
I know.
But unfortunately, I will not be able to come because they risk of quarantining me when I come back. And I will make a video of gratitude to all of you that will be projected. But I'm awfully sorry, but they put me in quarantine if I come back.
Alors bon congrès masqué. Bon congrès masqué à vous.
Bonne journée, au revoir à tous.
Allez, au revoir, au revoir.
Très bien. Monsieur Bismuth,
oui.
on va se parler une minute.
Oui, tu m'appelles.
On reste en ligne. Oui, je vous appelle.
Tu m'appelles. Au revoir, au revoir.
Très bien.
Au revoir. Tu m'appelles au téléphone, tout de suite.
Oui, tout de suite.